cardiology. What you will see is that we pull it out and talk about it prior to some of the content. Because one of the things that you will see about mental health and psychiatric pharmacology is that they are a major treatment for a lot of these disorders that Ms. Chandler is going to go over, okay? So it's very, very important for you to learn about these medications. One of the things that I will tell you is this lecture, as well as the therapeutic communication lecture, you are responsible for not only for this unit, but throughout 114. And you may see it again with the psych mental health content in 212. So this is important information to realize that it is going to be comprehensive, okay? So let's start talking about mental health pharmacology. One of the things that you will see is that you need to start learning your drugs by classifications. Because one of the things you find is, as a nurse, there are around 300 new medications introduced every year. And there's no way that you can learn all of the ones that are already out there, plus 300 more. So if you use the classifications, it's a better way to learn, because a lot of the drugs that are in that particular classification will have pretty much the same side effects. The major classifications of drugs that we use for pharmacology for psych mental health patients are the antidepressants, the mood stabilizers, the antipsychotics, and the anxiolytics. And that's what I'm going to talk about today, okay? All right, so antidepressants, and you can see here, these little pills have a smile on them, okay? What they do is to help try to relieve depression. One of the things that you will see is that the majority of your medications that work with psych mental health patients either affect dopamine or epinephrine, okay, two neurotransmitters. So antidepressants work for people with depression, which Ms. Chandler will talk about in her content, but just as an introduction, it's the most common mental illness out there. And one of the things that I will tell you that we are seeing with the COVID world is the incidence has increased, okay? Fewer than 50% of individuals with depression seek treatment, despite that 70% of them will have full remission with effective treatment. 66% of all suicides are related to depression. And with COVID world, that has increased, which is frightening. How does that patient with depression feel? Difficulty sleeping or sleeping too much. They're often fatigued. They either stress eat or they don't eat at all. And a lot of times you will have what we call somatic complaints or physical symptoms, such as stomach ache, headache, muscle pain. And that's due to the depression and not a physical illness. They often have problems concentrating. And lastly, those feelings of despair or lack of self-worth lead to poor self-image and will contribute to the problems that they have interacting with people. So there are 5 major classes of antidepressants. Selective serotonin reuptake inhibitors, SSRIs, most commonly used. Serotonin norepinephrine reuptake inhibitors, or SNRIs, the second most common class used. Monoamine oxidase inhibitors, or MAOIs, are not used as much as they used to be. They were one of the first drugs that was developed, but there are a lot of side effects with those. Another classification is tricyclic antidepressants, or you may hear them referred to as TCAs. Again, they were developed in the 50s and 60s, and there are a lot of side effects with those as well. Now, your atypical antidepressants that affect various neurotransmitters are the newest generation of antidepressants that have been developed. Okay, so let's talk a little bit about SSRIs. Now, this is sort of to help you understand. Am I going to test you specifically on this content? No. Basically, what you will see is that serotonin, or 5-HT, is released. And what happens is that when you have a reuptake that's blocked, you have more serotonin available. Serotonin is one of those neurotransmitters that help with mood. Serotonin, dopamine, norepinephrine. Okay? So, what you will see is that SSRIs block the reuptake so that there is more serotonin available. Again, am I going to test you on dosages? No, but I gave you these just as examples of what types of doses your patients may be on. SSRIs are the prams, citalopram, escitalopram, or the teens, fluoxetine, paroxetine. Okay? One of the things you will see is that whenever I test, I do use generics because that's what you're going to see on NCLEX. So the prams and the teens are examples of SSRIs. Okay? Other examples of the leans and the means, sertraline, fluvoxetine. Okay? Basically, what you will see is that SSRIs can be used for several different diagnoses. They can be used for depression, for anxiety, for obsessive compulsive disorder, as well as eating disorders. Now, certain drugs work best for different things, and that may be what Ms. Chandler is going to cover in her content. But SSRIs are probably your meds that are going to be used the most for helping with depression, as well as these other disorders. Now, SNRIs, selective norepinephrine reuptake inhibitors, bupropion, duloxetine, mirtazapine, phenylaxine, and trazodone. No specifics, endings here, okay? But SNRIs basically block the reuptake of norepinephrine, okay? Trazodone, a lot of times, is used as a drug that people would take at nighttime because it does cause sleepiness. It's often used for insomnia as well as an antidepressant. Now, your multimodals basically block multiple serotonin pathways. These meds may be used if those other folks don't get good response from either the SSRI or the SNRI. Since these block multiple pathways, then you will see that they may try these. Vortioxetine, the trade name was Trintellix. Unfortunately, there's another drug out there called Brintellix that it used to be called Brintellix, but it was confused with Brilinta Taragodor, which is an anticoagulant. And so they changed the name to Trintellix. You may see these used if SSRIs or SNRIs are not effective. Okay. Now, let's talk a little bit about side effects and adverse reactions of SSRIs or SNRIs. This is a K-DOD. These drugs take 2 to 4 weeks to take effect. Okay? So what you're going to see is that these patients may take these medicines for 2 weeks and say, I feel no different. This is not doing me any good. And what you're going to have to tell them is this. It may take a little longer to build up in your system for it to work. As a general rule, guys, all of your psychopharmacological drugs may take that 2 to 4 weeks. So just get that in your head. Common side effects: nausea, dry mouth, insomnia, somnolence, headache, usually to start off with. But those tend to go away. Nervousness, GI disturbances, usually diarrhea. Dizziness and anorexia may often occur. One of the most common reasons that men discontinue these SSRIs or the SNRIs is sexual dysfunction. It may cause impotence.
Yep.
So that is one of the things that you will see that a lot of people say, no, I can't do this. This is another K-DOD, guys. When you're talking about your patients with depression that are taking these meds, there is a what we call a black box warning. Okay? And that is a warning that's issued by the FDA that this is a major life-threatening side effect. A lot of these patients may experience suicidal ideation when they take these meds. Well, you're thinking, well, they're depressed and they may have already been suicidal. Why am I worried about these suicidal ideations continuing? The reason is This is when these people are more likely to follow through with their suicide plan because they feel well enough to follow through. So, with any of these patients that are taking either SSRIs or SNRIs for depression, suicidal ideation can be an issue, and it should be assessed for on a daily basis in the hospital or the mental health unit, or each time these patients come into the clinic. They feel now not quite so, I can't do anything right. And they may feel well enough to follow through with their plan. This also needs to be a warning to their family members that if they notice that their patient family member is talking more about suicide, that they need to get help. The other thing that you may see with SSRIs or SNRIs is something that we call serotonin syndrome. And that may be when a patient's taking another medication or herb that affects the synthesis or reuptake of serotonin. It can cause serotonin to accumulate in the body, and it can have some really adverse effects. With serotonin syndrome, it can be fatal. Serotonin syndromes usually occur as early as 2 hours after taking that first dose or as late as several weeks. As I said, it can be fatal. Mental status changes can occur, and you may see confusion, anxiety, restlessness, hypertension, tremors, diaphoresis, hyperpyrexia, or ataxia. What may cause the fatal outcome is the hypertension. It can cause stroke, or the hyperpyrexia. It can cause fevers of 105 or higher. And basically, you just fry your brain. If someone develops serotonin syndrome, they need to discontinue the medication. Often it will occur because people, well, I'm taking one pill, let's see if 2 will do better. Or they're taking an herb as a nutraceutical or a supplement that also increases serotonin. So serotonin syndrome is something that we as nurses need to assess for. MAOIs, or the monoamine oxidase inhibitors, okay? Basically, what you will see is that there's a release of dopamine, norepinephrine, and serotonin. The norepinephrine binds with that receptor, and what happens is that MAOI, or that MAO inhibits, norepinephrine is not broken down as quickly, and it produces a more dramatic effect. So what you see is that you get a mood elevation. Now, MAOIs were the first drugs that were approved in the 1950s to treat depression. Today, they're only used when patients don't respond to other antidepressants. The 3 that we most commonly use are isocarboxamide, phenylephrine, Allerine and transcycloprene, okay, Marplan, Nardil, or Parnate, okay? And the reason we don't use them as often is they have major side effects. It takes about 2 weeks to see any results. Again, that's a KDOD, that 2 to 4 week period you got to think about. Again, there's that black box warning. The herbs that people need to avoid with all antidepressants, and that includes the SNRIs or the SSRIs, ginseng, mahong, ephedra, and St. John's wort. All of them elevate serotonin levels. One of the other things that you'll see with
I have a question.
Sure.
Now, is the black box warning to avoid herbs? Or is
no, the black box warning is the suicidal ideation.
Okay.
Okay. One of the things that you'll see, the duration of these drugs is anywhere from 48 to 96 hours. And so typically what you're going to see is if a patient has been on an MAOI, they will let them come off of that med for probably 96 hours to up to a week before they start them on another medication because of the interactions that you see. Okay, so what you will see is that if you're on an MAOI, you have to come off of that med before they will start you on another. And it takes anywhere from 48 hours to 96 hours for that drug to clear from your system. Okay? Now, the side effects: dizziness, drowsiness, insomnia, orthostatic hypotension, nausea, anorexia, dry mouth, urinary retention. Okay? Again, suicidal ideation. When they start feeling better, it needs to be a very important nursing assessment to see if they have thoughts of harming themselves or killing themselves. MAOIs cause sexual dysfunction. They may also cause serotonin syndrome. But this is the biggie, the big KDOD with MAOIs. It can cause hypertensive crisis. I mean, the blood pressure shoots up dramatically. We're talking maybe 220, 240, over 120, 130. When foods with tyramine are ingested with that medication. Well, what is tyramine? It's an amino acid that is in a lot of food and a lot of drugs. What happens is you get an increase in the release of norepinephrine. Okay? And that is a catecholamine that stimulates that sympathetic nervous system. So what you see is that acute hypertension, flushing, their heart rate may be going 150, diaphoresis, and nausea. Calcium channel blockers can be given as an antidote to try to relieve that hypertensive crisis. Well, one of the things that you see is that this little slide shows you can't give barbiturates, tricyclic antidepressants, antihistamines, CNS depressants, antihypertensives, with the exception of that calcium channel blocker, or any over-the-counter cold meds. So there are a lot of meds that they can't take. There are a lot of foods that they can't have. No cheese, no wine, no pickled foods. or bananas, avocados, raisins, hard cheeses, chocolate, sour cream, yogurt, wine or beer. No hot dogs, no sausages, no deli meats. Any meat that is processed, they cannot have. I love this little meme. It says, I was slipping an MAOI into their drink and then offered them some cheese and wine. Okay? Because basically what it would do is cause that hypertensive crisis. So what you're talking about with MAOIs is that you have to have a patient that is extremely careful about what they eat, what they drink, and what can be prescribed to them or taken over the counter to prevent this hypertensive crisis. Now, TCAs, we'll do this and then we'll take a break. TCAs are tricyclic antidepressants. Were introduced into the in the late 50s to the early 60s. They were seen as an improvement over the MAOIs. Okay. Basically, what you will see is that they inhibit the reuptake of norepinephrine and serotonin. And what you will see is they will improve the depression as well. Now, the leans, amitriptyline, nortriptyline, empyramine, okay, this is one that they use a lot for migraines, are examples of tricyclic antidepressants. Clomipramide or anafranil is a med that's approved for obsessive compulsive disorder. Doxepin is one that we use quite frequently for people with anxiety. And we see tricyclic antidepressants used in small doses as treatment for childhood enuresis or bedwetting, okay? Often it's given as a nasal spray. Again, guys, that 2 to 4 weeks to reach those therapeutic effects. Well, why don't we use these more often, okay? The major side effect of TCAs is orthostatic hypotension. These people, if they rapidly stand up, will pass out. It dramatically drops blood pressure. Okay? So definitely, if a person is on a TCA, they need to be taught to get up very slowly. It does cause sedation in some people. That's transient. It usually gets better. But the other thing that you see are anticholinergic effects. Okay, tachycardia, urinary retention, constipation, dry mouth, blurred vision. Has anyone taught you the poem about anticholinergic effects? Okay, this is it.
Yes.
Can't see, can't sit, can't pee, can't shit. So those are the things that you will see with those anticholinergic effects: urinary retention, constipation, dry mouth, blurred vision. TCAs can also cause cardiotoxicity or seizures. They may contribute to sexual dysfunction, again, impotence. there are some blood dyscrasias that you will see, low platelets. If a person is on a TCA, they should be gradually decreased. You cannot abruptly stop them. They will have a withdrawal syndrome, nausea, vomiting, anxiety, and akathisia. That akathisia basically is an inability to move or slow movement, okay? Now, one of the other things that you will see about TCAs is that typically if a patient is prescribed a TCA, they will only give a 30-day supply of this medication. You know, most insurance want you to do the 90-day supply because it's cheaper for them. But with TCAs, they only do the 30 because an overdose of TCAs, either the basically would cause a successful suicide. It's the most common antidepressant that is successful for suicide, because what it causes is that severe orthostatic hypotension. And these people just do not get a blood pressure. Overdose, typically what you have to do is to dialyze them and support them with fluids. Okay, I'm going to stop sharing here. It's 11 o'clock. Let's be back at about 11 after, and we will resume.
Thank you.
Okay, we will, if you've got questions at the start, I'll answer questions before I get started back. And I've paused the recording, so there won't be a big blank in the middle.
Okay, thank you.
Okay, move. on the break, I looked in the chat and there are a few questions, and instead of individually answering them, I'm going to do that for the whole class because I think they're questions that everyone would want to know. Number one, can you record my section? Yes, I am recording. So I will post that once the recording gets converted. And basically someone asked, because there are a lot of medications to look through for the test, do we need to know the drug name that's in the parentheses? Usually the name in the parentheses is the trade name. It may be what your patients use. I will not test you on the specific trade names. NCLEX and I, as well as Ms. Rumble, just FYI, use generics because that's what you will be tested on an NCLEX. But patients may know the trade name because it's a little easier to pronounce, okay? Someone had a question about Kaplan remediation. If you would just go ahead and email me and I'll be glad to go over that with you. What was the best way that you would recommend studying for this portion of the test? I would tell you that probably using that F.A. Davis stuff with the advantage is really good. And I will try to see if I got any practice pharmacology questions that I can get you. You know, one of the things that I'll tell you, my questions, I could care less what's on the second paragraph and the third graph on page 43 in the book. You know, what I look for is nursing care. Is it going to impact my nursing care? Is it a side effect that's going to affect my patient? Is it something I need to teach my patient? Is it something I need to assess for? So knowing those classifications and knowing what I need to talk to my patients about is a good way to understand, you know, with this pharmacology. I'll give you hints with those KDOTs. The other thing is if you hear me say something more than once, that's probably a good hint. You know, I once had a student that was studying and doing group study, and they said, you know, I like Miss Hyde, but boy, she repeats herself a lot. And the other group looked at her like, you idiot, she's telling you what's important. Yeah. If you hear it more than once, it's probably important that you need to think about, okay? So that's a couple of study tips. Do we need to know the generic names for each antidepressant drug? What I would do is be familiar with what class they're in, okay? So that you can recognize, is it an SSRI? Is it an SNRI? Well, SSRIs and SNRIs have pretty much the same side effects and adverse effects. You need to know the difference between those and the MAOIs and the TCAs, okay? So that would be my suggestion. Know more about the class, okay? All right, so let me screen share with you again. And find where we are.
Miss Hyde, did you see my message about letting Becca back in? She said that she got kicked out during the break.
I think I've let everyone in the waiting room, but let me double check. I may have to stop sharing for a minute. Let me look for the waiting room. I don't see anyone in the waiting room, so hopefully she's on. Okay, now this is an antidepressant, esketamine intranasal. They can also give esketamine as an IV medication, okay? You may know it as ketamine, which is one of those meds that has been used for several years as an anesthetic agent. It was first used by veterinary medicine as a horse tranquilizer. It is also used in human anesthesia, especially whenever we're talking about patients that are undergoing procedures that they don't need to remember. It does have an amnesia effect, so to speak. Ketamine is also used as one of the club drugs. It can be one of those drugs of abuse as well. But one of the things they found about ketamine, and the FDA basically approved it last summer as a treatment for depression. It's indicated for treatment-resistant depression. It's used along with an oral antidepressant, okay? And remember, our TCAs, our MAOIs, our SNRIs, our SSRIs take 2 to 4 weeks to start working enough that these patients have a lift in their depression. What we see with esketamine is that there is an improvement in their depression in as few as 2 days after their treatment. So what you see with the use of this med is a lifting of the depression and hopefully a decrease in the risk for suicide. However, they're still given either that SSRI or SNRI as a continuing treatment, okay? If it's given, it's administered in the physician's office or clinic. These people are monitored for at least 2 hours after the administration because we have to watch out for hypertension or sedation. The other thing you will see is what we call disassociation. They're in a dreamlike state. They're sort of separated from the real world. And that's one of the reasons that it's used as a club drug, okay? How it works on depression, we really don't know. But a lot of times what you will see is that they will get 4 to 5 treatments of esketamine while the SSRI or the SNRI is taking effect. And it rapidly decreases that depressive state. Now, as you can see, it was approved in the summer of 2019. I have not seen any recent studies that say what the success rate is or any major side effects other than the ones that I've seen here. But whenever I see that study, I will let you know. But esketamine, either intranasal or IV, can be given as a rapid method of trying to help with that depression.
So this isn't used like continuously?
No, it's not.
Okay.
It is not. Typically, what you will see is that they will do 4 or 5 treatments while the oral antidepressant is building up in their system.
And they go to their doctor's office to get the treatments, and then they're monitored. Okay.
Right. And then they go home. Okay?
So would you see this with like a severe depression?
Yes.
Someone who wouldn't wait the 2 weeks?
Yes. I mean, it's one of those fairly, only 2 years old. So it's one of those things that I have not seen any long-term studies on it. But, it was, whenever it first came out, it made major ripples in the psychiatric mental health world because it was one of the first treatments that could rapidly help with patients with major depressive disorder. So it's one of those things that, it doesn't hurt to try it while they're building up that 2 to 4 week, level of medication in their system. Okay. Because one of the major problems that we get with patients that are depressed is the risk for suicide. And hopefully this will help decrease that. Okay, so now we've moved out of antidepressants into the mood stabilizers. And typically we will see mood stabilizers used for what we call bipolar disorder. In the old days, they call it manic depressive disorder. But bipolar is the more correct terminology because we may see patients with only manic phases and no depressive phases. Okay. Or we may see people that what we call cycle, moving back and forth between the two. Now, I know that Ms. Chandler is going to cover bipolar disorder, but this is a good, really synopsis of bipolar disorder when you're looking at signs and symptoms. Okay, so save this slide to help you study for that. A lot of times with bipolar disorder, you may see cycling back and forth. You may see grandiose behavior. They're very dramatic at times. You may see decreased sleep. They feel great. Extremely talkative. They may have what we call flight of ideas. And that's bouncing from topic to topic to topic to topic that may not be related at all. Easily distracted. They may have what we call increased goal-directed activity. A lot of creative people, artists, musicians, are manic depressive or bipolar. A lot of times you will see excessive involvement in pleasurable activities, such as sexual activity, promiscuity, multiple partners. Lithium is a drug that we use often for bipolar disorder, and you can see lithium, okay, is one of the mnemonics that we use for this medication. Lithium, the level of therapeutic effect, 0.6 to 1.2 milliequivalents per liter is the therapeutic range. It's very narrow, okay? If you go low, like 0.3, they may still have symptoms of mania. If you go over the 1.2, you may have symptoms of lithium toxicity. The eye, indicate mania. Toxic level is 2 to 3. And you see impaired consciousness, tremors, seizures, dysrhythmias. With your patients that are on lithium, is it extremely important that they hydrate. 2 to 3 liters of water per day or other liquids. Lithium does cause an increased urinary output. It may cause a dry mouth as well. Usually sugar-free candy, like the mints, will help with that. However, be careful with a lot of sugar-free candy. If it contains sorbitol, it can cause diarrhea. The U is, give mannitol if toxic signs and symptoms are present. And the M is we want to maintain their sodium intake of 2 to 3 grams per day. These people should not be on low sodium diets. Lithium acts like a salt. And what happens is if this patient is losing sodium, the lithium is retained by the kidney and can build up to that toxic level. So with our patients, 3 things that we want to be able to teach them: 2 to 3 liters of water a day, maintain sodium intake, and get your blood level checked on a regular basis, because we want it to stay in this therapeutic range. You may hear it referred to as escalith. Okay, lithium, of course, is the generic name. Again, that risk for toxicity is high. As I said, it acts like sodium. If you lose sodium, the lithium will adhere to the cells. Typically, we treat lithium overdose with hemodialysis to remove that drug from the system. As I said, side effects: dry mouth or thirst, increased urination. It may cause weight gain or bloated feeling. Some people say that it tastes like you're chewing aluminum foil. There's a metallic taste. Sometimes it can cause edema in the hands and the ankles. Some other precautions: it should not be taken with NSAIDs, such as ibuprofen or naproxen. Caffeine and loop diuretics like furosemide or Lasix can cause a decrease in your drug levels. So it may lower that therapeutic range. We use it in caution with patients with cardiovascular disease, because think about it. Typically, we don't want those patients to be on regular sodium diets. We want them to be on low sodium diets. We don't want them to have a larger intake of fluid. So we have to use it very cautiously in patients with cardiovascular disease, because it risks putting them into heart failure. Again, we want frequent monitoring of levels. Is it in therapeutic range? And then we want to do labs to check for sodium, for chloride, and making sure that they've got adequate fluid balance. Now, toxicity, this is what you usually see early on. Diarrhea, drowsiness, loss of appetite, muscle weakness, nausea, vomiting, slurred speech, and trembling. Later on, as that level increases, you see blurred vision, confusion, much more urination. You may see convulsions or seizures, extreme trembling, and very, very unsteady. They're ataxic. They're unable to walk without falling.
Did you say lithium is a mood stabilizer or an antipsychotic?
It's a mood stabilizer.
Okay, thank you.
Okay. Now, other meds that they use for mood stabilizers are a lot of the anticonvulsants. And you'll see that anticonvulsants not only can be used for seizures, they can be used for mood stabilizers, they can be used for pain, for chronic pain. Valproic acid, carbamazine, or lamotrigine are 3 drugs that they use quite often for mood stabilizers. Now, why do we worry about anti-seizure medicines? Well, Stevens-Johnson syndrome can occur. And in every drug that you ever look up, you will see Stevens-Johnson syndrome in the bright red, bold capital letters, okay? Well, what happens with Stevens-Johnson's is it's not just a rash. It's a rash that basically your skin peels off. And you have to treat that patient like they've got a burn. And it can also happen in the internal mucosa, which may mean that that person has to get a gastrostomy tube in order to eat until healing has occurred. Liver failure, aplastic anemia, drowsiness, and sedation can occur. And then with Depakote or valproic acid, you can see increased bleeding time. So those are some side effects. You know, the drowsiness and sedation often decreases as they become more used to the drug. But these others, they're still at risk for. Now, some of your atypical antipsychotic medications that they use for mood disorders, apiprazole, olanzapine, risperidone, and zaperidone. Probably risperidone and apiprazole are the ones that you see most often. A lot of times you will see these used for your patients with bipolar disorder. You may see them used for your patients with Alzheimer's as well. That's an off-label use that has a black box warning. It increases the risk for heart attack in your patients with Alzheimer's. They're not recommended, though occasionally they will be prescribed to help with some of the behavioral issues. But there is a black box warning on those. Now, I know that Ms. Chandler will also go over schizophrenia and other psychotic disorders. Now, these meds have been around for quite a while. Some of them have been, at least. With schizophrenia, basically, you may see delusions or hallucinations, disorganized speech, or grossly disorganized behavior, diminished emotional expressions. A lot of times their behavior is exceedingly bizarre. The hallucinations may be either voices or visual. The delusions may be that the TV is telling them to do something. Okay? So schizophrenia, it has to be for at least a month. And usually one, 2, or 3 has to occur. What's really scary about schizophrenia is, unfortunately, it usually attacks in the early adulthood, the late teens to early 20s. Okay? So that what you see is that they may have what we call their first psychotic break when they're away at college or alone for the first time. Now, one of the things you'll see with antipsychotic meds, you have your typical and you have your atypical. Your typicals are the meds that were first developed for psychosis. And those are your phenothiazines. They block norepinephrine and dopamine. Now, phenothiazines have other uses other than antipsychotic medications. Phenergan, that we often give for nausea, is a phenothiazine. Probably the ones that you see most often here used for antipsychosis is promethazine, or the non-phenothiazines is thiopixine or aldosterone or Haldol. You may hear it referred to as vitamin H by some older nurses. Haldol is a medication, a non-phenothiazine, that we use often to try to decrease behaviors that are not desirable. Like you may give it for hallucinations or delusions or delirium in order for them to sleep. But it can cause some major side effects. Your typical antipsychotics, as I said, they block dopamine, cholinergic, alpha-adrenergic, and histaminic receptors. They produce sedation, those anticholinergic effects. Can't pee, can't sit, can't spit, can't pee, can't shit. Okay? So those are things that you will see with these meds. They also cause orthostatic hypotension. Your typical antipsychotics, this is a KDOD, guys. You may also see what we call extrapyramidal symptoms and what we call tardive dyskinesia. Your extrapyramidal side effects I'll talk about in a little bit, as well as the tardive dyskinesia. Your atypicals are the second generation. They're newer. They're the ones we use most often today. There's less chance for those side effects, especially those extrapyramidal ones, especially agranulocytosis and the anticholinergics. These don't block dopamine receptors as much, but they block serotonin, cholinergic, and histaminic and adrenergic receptors. Okay? So your atypicals basically block some of those transmitters across that synaptic junction. These are what your atypicals are. Look at these. They're the penes and the dones. Okay? lorazepam, risperidone, ziprasidone, olanzapine, quinine, okay? These are your atypicals. A lot of times you will see this one, Seroquel. It says 300 to 400 milligrams a day. A lot of times they will give this one at night because it does cause such sedation and it will help them sleep. Okay. Now, this is a special atypical antipsychotic, and this is a kadioti. This whole slide is a kadioti, guys. Clonazepam is indicated for severely ill patients with schizophrenia that do not respond to any other treatment. One of the things that you will see is that these patients are at great risk for agranulocytosis when they're on this medication. So people that are on clonazepam have to have white blood cell counts and absolute neutrophil counts monitored to prevent or greatly reduce the risk of that agranulocytosis. If a patient is prescribed this medication by a psychiatrist or a mental health nurse practitioner, they are required to be on a national registry, and frequent follow-ups are required for blood tests because the risk is so great for that agranulocytosis. Okay? It's the only med that has that severe risk. So the clozapine, remember that. Now, what is an extrapyramidal syndrome, EPS? It's a major side effect of typical antipsychotics, and sometimes we refer to it as pseudo-Parkinsonism. That stooped posture, that masked-like face, or resting bitch face. Okay, no expression, no smile. A lot of times you will see rigidity, tremors, that shuffling gait, that peel rolling motion of the hands, and bradykinesia. Bradykinesia means slow movement. Okay, like the patient has Parkinson's, but it's caused as a side effect of that antipsychotic medication. Usually during the early treatment period, you can see another thing called acute dystonia, where you may have muscle spasms of the face, tongue, neck, facial grimacing, or laryngeal spasms. These are treated with anticholinergic anti-Parkinson drugs such as benzotropine. A lot of times these patients will have akinesia, trouble standing still, their restlessness, they pace, they're in constant motion. Sometimes it's treated with a benzodiazepine like lorazepam or Ativan, you may know it as, or a beta blocker like propranolol, okay? Early on, that's what you will see. Yeah, Becca, what was your question?
So for these adverse effects, are these only for the typical or for both typical and atypical?
They're more for the typical, but the atypicals can cause them to some degree.
Okay.
Okay.
So for testing purposes.
For testing purposes, you're more likely to see them with the typicals.
Okay, thank you.
Mm-hmm. Now, tardive dyskinesia. typically occurs in patients that take a typical antipsychotic for more than 1 year. You may see lip smacking, tongue thrusting, jaw movement, facial grimacing, or involuntary movements of the body and extremities. Okay, let me stop share for a minute and let me show you typically what you will see with this tardive dyskinesia is okay, they look really strange, and it's a side effect of their medication, and it's not anything they can control. Something like that. And you can imagine how it does decrease quality of life for these people. Okay?
And this is permanent, or it goes?
It can be. Can be.
Okay.
Sometimes if we catch it early enough, it can be reduced. But think about, if you're making all of these strange movements and you tell the doctor about it, oh yeah, that's a side effect of your medicine. How likely are they to adhere to their drug therapy?
Not very likely.
Not very likely at all. Now, one of the things that you will see, guys, is that ondansetron or Zofran, okay, is not an antipsychotic medication. It's one that we give for nausea, specifically a lot of times with our cancer patients that get chemo. One of the things that's happened in the past 5 years is that they found that high doses of ondansetron that we were giving for chemo patients can cause a permanent tardive dyskinesia as well. And the way that they found that out is that a lot of patients, the chemo was successful and they were living longer. So one of the things they've done is actually decreased the amount and the frequency of ondansetron for nausea to ward off these side effects. Now, one of the things that you will see is that last year, the first medicine to treat tardive dyskinesia came out. Valbenzazine or Inzegra. Okay, it's a very highly selective monoamine transporter 2 inhibitor, whatever that means. Okay. It was approved by the FDA, I want to say in 2020, but it does have side effects as well. Sleepiness that gets a little better, but does not completely go away. The other thing is that you might see with it is what we call QT prolongation. And that can be a problem with our patients with cardiac disease because it increases the risk for them to develop ventricular fibrillation. Okay, so it's used very sparingly in your patients with cardiac disease, but it's the first and right now the only med that we have to treat the tardive dyskinesia. Basically, this is a slide that shows you what we've just gone over, okay? The pseudo-Parkinsonism, the acute dystonia, the tardive dyskinesia, and the aphakinesia, that restlessness, that trouble standing still, that feet inconstant motion, that foot tapping. Drives you crazy when you're trying to take a test. But these are things that you see from antipsychotics. Typically what happens is that they're sedated. They've got orthostatic hypotension, dry mouth, constipated, blurred vision, weight gain, those bizarre movements, and they may have that white blood cell count extremely low. That's why we have lots of problems sometimes keeping these patients on these antipsychotics, because drug adherence is the most common reason, or not adhering to drug regimen is the most common reason that your psychotic patients are readmitted to the hospital. Now, there is another horrible side effect that can occur, neuroleptic malignant syndrome, that often occurs in your patients with antipsychotic medications. If a patient has excessive agitation, exhaustion, or dehydration, they're at greater risk. With neuroleptic malignant syndrome, you will see muscle rigidity, hyperthermia, profuse diuresis, blood pressure fluctuations going from hyper to hypotensive, tachycardia, dysrhythmias. You may see seizures. But what usually causes the fatal blow for these patients is the rhabdomyolysis, which in turn causes an acute renal failure that may lead to respiratory failure, coma, and death. Okay? I have been a nurse for 42 years. I've only seen one case. It was a gentleman that was Hispanic, did not speak very much English, had a psychotic episode and was arrested, brought to a hospital, local hospital, to be evaluated before he was taken to jail because his behavior was so bizarre. Unfortunately, whenever they transport from mental hospital to mental hospital, they're handcuffed feet and hands in the back of a police car. Again, this gentleman did not speak much English. So he probably didn't know what was going on very well. In addition to his psychosis, he was not thinking very well. When they got him to the hospital that I was working at, he didn't want to come in. And basically, they had to pry him out of the squad car. They put him on a gurney to bring him up to the mental health unit. He continued to try to not go wherever they were taking him. And unfortunately, what happened is that he got an injection of an antipsychotic medication because his behavior was so combative and so dangerous to staff and other patients that they had to control that behavior. And he was placed not only with that injection, but was placed in seclusion. Well, excess agitation, exhaustion, and dehydration. We had no clue the last time he ate or drank. He developed this neuroleptic malignant syndrome and had to be taken to the ICU, sedated, dialysis performed to keep him from going into acute renal failure. I think his temperature when we checked was 105.6. Now we're talking about a 20 5-year-old. You rarely see temperature that high. But he was stiff as a board. You could not bend any of his joints. Blood pressure was fluctuating everywhere. But those predisposing factors and the administration of that antipsychotic threw him into this neuroleptic malignant syndrome. Now, the third generation antipsychotic are these dopamine serotonin system stabilizers. These are ones that you may see as adjuncts or in addition to your antidepressants in your patients with major depressive disorder or bipolar disorder. Aripiprazole or brexpiprazole, Abilify and Rexulti. Those are the ones you see the ads for on TV. Is your antidepressant not doing the full job? Add Abilify and it will help, okay? These are typically used as adjunctive therapy, okay? So you may see these used for your antipsychotic medications as well. Now, what if that patient cannot or will not take their medications by mouth? One of the things that you will see is that the majority of our patients that sort of come in and out of the hospital and the mental health unit are because of lack of compliance with medication regimen. If they can't take them by mouth or will not take them by mouth, a lot of times what you will see is that the psychiatrist may go before the court and get what we call a court order to make them take their meds. So that what happens is that this would be an outpatient clinic that they would go to. Paliperidone or Invega Sustenna or some of the other medications that I've listed below are usually good for about a month, okay? Invega Sustenna, typically you would get 2 injections in the hospital about a week apart. And then they go monthly for about 3 to 4 months. And then you may see them go every 6 weeks. So you can get an involuntary outpatient commitment to require these patients to take their meds. Say, for example, the patient has an appointment to get their Invega Sustenna. They don't show up. That clinic can send the police to pick them up, bring them in, and we can force administer those medications. Okay? So these are long-acting, and they work very well with patients that don't stay on the medication regimen. And as I said, it's called an involuntary outpatient commitment for medication administration. And it has to be issued by the court system. Okay? Now, anxiety or OCD or obsessive compulsive disorder or any other related disorder. Anxiety is a very common illness You typically see palpitations, diaphoresis, shortness of breath, nausea, faint, dizziness. You know, that feeling you get before you take the final exam, okay? Like times 6. But it's very common in a lot of people. Probably the most widely prescribed medication for anxiety is a benzodiazepine. They have a very high potential for abuse. As a general rule, guys, benzos, you may hear them referred to, should be short-term use only. We're talking a week or less for anxiety or muscle relaxation. Now, seizure meds, we may use them longer. But again, they have a very high potential for abuse for both physical as well as mental addiction. They should not be combined with alcohol because they can cause respiratory depression. They do have a very long half-life. If patients have been taking benzodiazepines for quite a while, then you should not stop them abruptly. They will withdraw, and it can be life-threatening. So typically they taper those meds and then discontinue. KD-OD, KD-OD, KD-OD. Flunarizumab is the antidote for benzodiazepines overdose. What is the antidote for opioids?
Narcan?
Narcan or naloxone, okay? Get used to the naloxone, okay? Naloxone does nothing for benzodiazepines. Typically, what you will see is that if they have a patient that's suspected of overdose, they will do naloxone first because it's more likely that they've overdosed on an opioid. If that doesn't work, they may try the flunarizumab. Okay? This is an antidote you need to remember. Basically, with anti-anxiety medicines, they depress the CNS. The way that they work is they potentiate the effects of GABA, okay, which is a relaxing neurotransmitter to produce that calm effect. We have to be very careful with our elderly patients or with our patients with hepatic or renal issues. Again, alcohol can increase the effects of those anti-anxiety medicines. These are the lambs and the pams, okay? The only separate one is the pate, okay? Lorazepam or Ativan, diazepam or Valium are the ones that you're going to see a lot. Altazepam or Xanax is probably the one you see most often prescribed for anxiety. Now, there are some other anxiolytics. Buspar or buspirone is one that you will see. It doesn't affect the CNS. We don't know how it works. It does take about 2 weeks to see effects. Drowsiness and confusion can occur. This one does not cause tolerance, meaning that if you're taking one of the benzos, you become tolerant to that dose and may have to increase the dose to get the same effect. But buspirone does interact with grapefruit or grapefruit juice, and it can lead to drug toxicity. Because what that grapefruit or grapefruit juice does is it blocks the ability of the body to break it down. So it can cause toxicity. Grapefruit or grapefruit juice is one of those things that you always remember too. You avoid it with pretty much a ton of drugs. All of your cardiovascular, which of these meds would, which of these foods would not be appropriate for this patient taking whatever's med. Always pick grapefruit juice because 9 times out of 10, you're going to be right. So, what questions do you have about psychopharmacology? Any? All right, well, let's go ahead and take another break. I've got that it's 12:08. Well, 12:09 now. Let's just do 5 minutes so that we keep on time so that you guys can get lunch break. So be back at about 15 after, and we will do the therapeutic communication talk. Okay?
Okay, thank you.
As I said, now we're going to go and do the therapeutic communication handout. So let me share my screen with you. All right, therapeutic communication is one of those techniques that we use as nurses that's different than talking with your friends. I mean, one of the things that you will see is that as the nurse, you're talking with this patient to gather information or to help them make decisions. You are not their friend, trying to say, oh, everything will be all right. It is one of the topics that you will see that's very important when we're talking about dealing with psychiatric mental health patients, as well as patients throughout your nursing career. So, what is therapeutic communication? Well, it incorporates both verbal and nonverbal responses. It understands that client's needs. We actively listen to what that client is saying. And then it also promotes clarification and perhaps gives insight about that client's condition. Okay? Each of these things we are verifying with the client to make sure that we are interpreting what they say, what they do correctly. Now, one of the things that you will see with your book, it talks about active listening and using SOLER, SOLER, as a technique. S is sitting squarely facing the client. O, observing an open posture. L, lean forward towards the client. And E, establish eye contact. And then R, relax. Don't be tense, is what it's basically saying. Now, one thing that I will tell you, this is good for your med-surg clients. Be careful about leaning forward with your psychiatric mental health clients. You want to give them their personal space. Leaning forward, touching, like a calming gesture, often is misinterpreted as attack. And it can be very frightening for the patient, and they may lash out. So be careful with that lean forward or touching to reassure with your mental health patients. It's better if you don't. Give them their space. Do not touch. Okay? Some of the techniques: silence. Typically, one of the things that is most likely to cause people to talk is asking them a question and then being silent. A lot of people don't like silence. It's uncomfortable for them, and they're more likely to answer. Other techniques are accepting, giving recognition, offering self. I'm here if you need to talk. Broad openings. Placing the event in time. Now, this happened when, or this happened after you had your accident. Encouraging descriptions. Go on. Tell me more. Attempting to translate the words into feelings. You seem sad about that. Restating. When you said that you have nothing to live for, you feel that you're a failure. Focusing and exploring, seeking clarification, presenting reality. I understand that you're hearing voices, but I don't hear anything. And helping formulate a plan of action. Make sure you look at the book with each of these therapeutic communication techniques. Now, things that are non-therapeutic, giving false reassurance. Oh, I'm sure that everything will be all right. Or things will look better in the morning. Rejecting. Oh, don't do that. Approving or disapproving, agreeing or disagreeing. Giving advice. Well, if it were me, I would do this. Not your role as the nurse. Probing. Basically getting every little detail. Like you're doing a questionnaire and have to fill in all the blanks. Defending. Well, your doctor knows best. Belittling those feelings. Your mother died 6 months ago. Why are you still grieving? That's belittling. Or stereotyped comments. Or introducing an unrelated topic when they're talking about they have thoughts of killing themselves, and then you move to, well, what did you have for breakfast this morning? Avoiding the topics because you're uncomfortable with it. NCLEX and therapeutic communication. These are the steps that we look at, assess verbal and nonverbal client communication needs. Respect that person's personal values and beliefs. Not everyone thinks the same. Not everyone believes the same. But as a nurse, we need to respect that client's personal value. We need to allow time to communicate with that client. Currently on NCLEX, it doesn't matter how many patients you've got. You sit down and talk with that client. We want to encourage them to express their feelings. And then evaluate, were we effective in communicating with that client? They are the most dreaded communication questions because typically I will tell you, a lot of my students tell me, when I see a therapeutic communication question, I pick the one answer that I would never say, and that might be the right answer. You know, if I'd say this to a friend, it's not what I would say to a patient. Again, assess those family dynamics to determine that plan of care. Look at psychosocial, spiritual, occupational factors that may affect care and help plan the interventions. Look at those nonverbal clues to physical and psychological stressors. If that patient is telling you, I'm having no pain, but they're grimacing and restless, those two are not congruent. You want to use those therapeutic communication techniques that we listed on one of the previous slides to help them provide client support and provide that therapeutic environment for the client, especially with emotional or behavioral issues. Therapeutic communication is key in helping these patients with psychiatric mental health illness. Now, a couple of things that you can do to sort of help narrow questions down. Eliminate options that indicate the use of poor therapeutic communication techniques, like the nurse tells the client what to do without regards to the client's feelings or desires. Well, I think you should do this when the client's told you that they're not really willing to undergo chemotherapy. And the nurse says, well, I think you should do it. If you ask a question that can be answered yes or no, remember those open-ended questions. But I'm going to give you a caveat here. In patients that are under extreme crisis, or your patients that have dementia, those open-ended questions often are untherapeutic because they are unable to form thoughts and get their needs across. Sometimes in those situations, in those extreme crisis moments, or with your patients with dementia, yes or no questions are appropriate. But as a general rule, otherwise they are not. Another thing that you want to do is eliminate options that seek the reason behind their behavior. Well, why did you do that? That is not therapeutic communication. Again, we want to eliminate options that implies disapproval of the client's behavior. Well, why did you eat that donut when you knew it would elevate your blood sugar? Offers those false reassurances. I'm sure you will do very well in surgery. You're not going to die. If you attempt to interpret the client's behavior rather than allow them to verbalize their own feelings. If you offer a response that focuses on the nurse, not the client. You know, I had that same surgery and this is what, no. It's not about you. It's not about you. It's about that client. Focus on them. These are some do nots. Don't approve or disapprove. The nurse does not have the right to pass judgment on whether the ideas are good or bad. That's good. I'm glad you, or I'd rather you wouldn't. Or reassuring, whether it's either false reassurance or just reassuring. I wouldn't worry about that if I were you. If I say I wouldn't worry about it if I were you, basically discounts what that client is feeling and makes them feel like I shouldn't feel this way because it's not important. Rejecting or refusing to consider or shows contempt for that patient's behavior ideas. Let's not discuss that. Or I don't want to hear about what you did. If that nurse interprets, they're telling the patient the meaning of his or her own experiences. Now, there's a difference between interpreting and restating. Restating, what you're trying to do is to clarify what they said and what they meant. Interpreting is putting your own interpretation on what that patient's behavior was. Probing is another thing. Persistently asking questions and pushing for answers that patient may not want to reveal is non-therapeutic. This is not the Inquisition. So those are things that you don't want to do. Giving advice. This means that, you know, the nurse knows best. You can't think for yourself. Well, I think you should do this. They have to make their own decision. Defending, protecting someone or something that the patient has no right to express ideas, opinions, or feelings is what it basically says. I'm sure your psychiatrist only has your best interests in mind. That's why they did so and so and so and so. You listen. You don't have to defend. When you answer these types of questions, these are things you want to look for. Look for responses that allow the client time to think and reflect, that encourage them to talk, that encourage them to describe a particular experience, or that reflects that the nurse listened to the patient, such as paraphrasing that client's response. Those are probably going to be the right answers on therapeutic communication questions. One of the things that you'll see is that therapeutic communication is the foundation for developing that nurse-client relationship. You need to listen intently to what the client is saying and not be distracted by documentation or filling out forms and things like that. We want to rephrase key client statements. Use those broad openings and general statements to initiate conversations in the majority of our patients. We need to ask the client to clarify any confusing or vague message because that shows your desire to understand what they're saying. And then lastly, silence is golden. It gives that client time to talk, think, or maybe gain insight into their own problems. Now, nonverbal communication. One of the things that you see is that about 60% of our communication is nonverbal. Our appearance, our dress, our body movement, and our posture, touch, facial expressions, eye behavior, rolling of eyes. How many of you, I don't know if any of you have teenagers, but Lord help you with eye rolling behaviors. Vocal clues, pitch, volume, intonation. Usually what we see is that loud volume or a harsh intonation means anger. And so those are clues that we see that are nonverbal. If you look at this first guy here with his legs crossed, does he look interactive with that patient? No, he looks like I'd rather be anywhere else than right here, right now. This guy looks like he's about to take off running. And this guy basically says, I don't believe anything you're saying. So those nonverbals often are contraindicating or contradictory to what you may be saying. Okay, let's walk through a few questions. Question 1, a mother is notified that her child was killed in a tragic car accident, states, I cannot bear to go on with my life. Which nursing statement conveys empathy?
Four.
Okay. What about number 1? This situation is very sad, but time is a great healer.
Don't tell me that.
You can't predict that.
You can't predict that. Time is a great healer is one of those old saws that you hear that's sort of false reassurance. You're sad, but you have to be strong for your other children. What does that say to that patient? Well, this kid wasn't important because you got others. Okay. Once you cried out, things will seem so much better. Again, false reassurance. So 4 is the answer. Okay. You're basically, it's horrible to lose a child. I'll stay with you until your husband arrives. It's empathy. Empathy is the ability to see the situation from the client's point of view. Typically, what you are going to see is that nurses convey empathy versus sympathy. Okay? Empathy is considered to be one of the most important characteristics of that therapeutic relationship between patient and nurse. All right, let's look at number 2. Which therapeutic communication technique is being used in the following nurse-client interaction? The client says, my father spanked me often. The nurse says, your father was a harsh disciplinarian.
One.
Actually, it is number 1. That's a restatement. Okay, it involves repeating the main idea, and it allows the client to know if the statement has been understood, or it provides them an opportunity to continue. Okay. sometimes if you restate it as a question, it allows them to say, no, that's not what I meant, or yeah, that's what I meant. Okay.
Is that
All right.
more appropriate to do it as a question versus a
Yes.
statement? Okay.
Yes, it should be more of a question. Which therapeutic communication technique is being used in the following nurse-client interaction? The client says, when I am anxious, the only thing that calms me down is alcohol. And the nurse says, other than drinking, what alternatives have you explored to decrease anxiety?
Would that be 3?
This is 3. It's formulating a plan of action. Okay. The nurse doesn't say, well, drinking is not the answer, but it says, other than drinking, what else have you explored? Okay. It's formulating that plan of action. We don't approve or disapprove of drinking as that calming method, but we want to see what else they may have tried. Okay, let's look at this one. The nurse is interviewing a newly admitted psychiatric client. Which of the following nursing statements is an example of offering a general lead? Three is correct. Yes, I see. Go on. That means tell me more. Okay, look at number 1. What does it have in there?
Why?
Why you are here. Whys are never right. Okay. Are you feeling depressed or anxious? How could they answer that?
Is that one too open-ended?
That one is too close-ended. It's going to be
Close-ended.
yes or no.
Okay.
Okay. Can you order the specific events that led to your admission?
No.
No. Okay. 3 and 4, basically 2 and 4 are yes or no. This one is that why. We don't want to pick why. General lead is basically something that would give you additional information. Okay. It encourages them to continue. All right, let's look at this one. A nurse says to a client, things will look better tomorrow after a good night's sleep. This is an example of which communication technique?
Four.
4 is correct. It's non-therapeutic because what is it doing? It gives false reassurance, right?
Yes.
Yep. All right. Look at 6. Client diagnosed with post-traumatic stress disorder related to a rape is admitted to an inpatient psychiatric unit for evaluation and medication stabilization. Which therapeutic communication technique might a nurse use that is an example of broad openings?
Three.
2. 2 is probably the best answer. Okay. Look at this one. What occurred prior to the rape and when did you go to the emergency department? That basically is sort of passing judgment on her behavior, correct?
Yes.
Okay, so that's not therapeutic. I notice you seem uncomfortable discussing this. That may be okay, but is it the best? How can we help you feel safe during your stay here? Maybe okay, but again, not the best. The best one is, what would you like to talk about? Okay. One of the things, and we will talk more about rape syndrome and dealing with those clients in 212. basically what we do as nurses in the emergency department is let them know you're in a safe place. If you want to talk about it, I will be glad to talk with you. But it probably is better if they talk with one of the sexual assault nurse examiners. Okay? So that broad opening of what would you like to talk about may be the best for this client. Our favorite types of questions. Select all that apply. Which of the following characteristics should be included in a therapeutic nurse-client relationship? And without reading the content, I don't know that you can get that, but we'll see.
I'm going to say 1, 4, and 5.
Okay. And I'm going to say 2, 3, 4, 5. Okay, let's look at that. All right. Meeting the psychological needs of the nurse. No. The nurse, we don't care about the nurse. We care about the client. Okay. 2, ensuring therapeutic termination. That's one of those things that you always do at the end of your clinical day. You go say goodbye to your patient, correct? Yeah. Promoting client insight to problematic behavior. That is part of the therapeutic relationship. Collaborating to set appropriate goals and then meeting the physical and psychological needs of the client. Okay. If there is a focus on the nurse, that is not a correct answer. Okay. Patient states, I don't know what the pills are for and why I'm taking them, so I don't want them. Which is an example of the therapeutic communication technique of giving information.
Three.
4.
4 is the best answer. Okay. Number 1, you must take your medication to get better. Does that give them any information about what the pills are for?
No.
No. The doctor would not prescribe these pills if they were harmful. That's defending.
Mm-hmm.
Why do you feel this way about all your medication? Or do you feel this way about all your medications? That's actually confrontational, isn't it? Basically, this medication will help you to improve your mood, gives them information about why they are, what they're for and why they are taking them. Okay. All right. A client in an outpatient clinic says, I'm tired of these medications. Which nursing response is best to encourage the client to elaborate further? Two. Basically, you're restating what he just said. You're tired of taking your medications. Okay. Why would 4 not be an option?
Because it's about the patient, not the family.
Correct. Okay. That's exactly right. Focus on the patient. All right. I think this is the last one. Patient in a psychiatric unit tells the nurse, I'm all alone in the world now and I have no reason to live. Which response would the nurse is best to encourage further communication by the patient?
1.
1 is correct. Okay, it shows empathy, you're restating. And one of the other things that I'm going to tell you guys, and I'm sure Miss Chandler will go over. If they say, I have no reason to live, after this statement, you should ask 3 questions for suicide prevention. Are you having thoughts and feelings about harming or killing yourself? If they say yes, the next question is, do you have a plan? And what is it? And do you have the means to carry out that plan? One of the things that a lot of people think is that they don't want to mention suicide or harming or killing people themselves because they think it will put that idea in their head. That is the furthest thing from the truth. These people have thought about it, have planned for it, and may have already gotten the means to carry out that plan before you even mentioned that. As a nurse, if you have patients that are saying things like, I have no reason to live, the world will go on without me, then those are questions that you need to ask. Because if they do have thoughts or feelings of harming or killing themselves and a plan, then the healthcare provider needs to be notified immediately. Okay. Now, Kaplan talks about some common strategies. Eliminate the don't worries. Eliminate the explorers, never ask why, eliminate the authoritarian answers, well, do this, eliminate the focus on the nurse, and then eliminate closed-ended questions. And I'm going to give you that with a caveat, except for your patients with dementia, okay? These are some other information about those types of things. Okay. And this is what Kaplan does to help you with that therapeutic communication. So here we are, nursing school, when you're behind before the semester even started. I know that's probably how you're feeling right now, especially when this long day. But what I would say is read through the content that I've assigned. Look at your PowerPoints. If you have questions, please contact me. Even though my office hours are mostly on Tuesdays, you can always text me and I'll get back to you. If the answer is too long to do via text, I'll shoot you an email and I'll just tell you via text, check your email. Okay. So please feel free to ask questions. That's what I'm here for. Okay. All right. It is lunchtime, guys. So I know that Ms. Chandler has sent you the thing for this afternoon. If you have questions or concerns about the psych sim schedule, just shoot me an email, or if you've got to switch with somebody, that's not a problem as long as I know about it beforehand and my groups don't go over 4. Okay. All right. I'll talk with you later. I will post the recording whenever it gets converted. Okay.
Okay. Thank you so much.
All right.
Thank you.
All right.